Okay, class, welcome to the cardiovascular system. In this unit, we'll be covering the cardiac portion of the cardiovascular system. Our later lecture will be diving into more of the vascular aspects of the cardiovascular system. Um, our objectives we have here, so we're going to demonstrate an understanding of cardiac physiology, especially with a focus on cardiac electrophysiology, with a emphasis on the cardiac conduction system, basically the background physiology for how the ECG, kind of like what creates the ECG signal that we capture. We'll go over autonomic control of heart rate, as well as the pumping properties of the heart with a focus on contractility and cardiac output. So before we kind of dive in, let me get rid of that there. Sorry about that. We'll cover again a general overview of what the cardiovascular system does. Its primary role, and its basic anatomy. You can think of the cardiovascular system as a system or a pumping system, right, or plumbing system, where we have a central pump here, the heart. It's connected to it are arteries and arterioles. Then we get into our network of capillaries down at the tissue level, which is where we diffuse gases, move metabolic waste, and perfuse organs. It occurs in these capillaries. And then we have our waste removal system, with our veins, which return metabolic or return metabolic byproducts such as carbon dioxide back into the pulmonary circuit to be reoxygenated. And then we also have a waste removal system in the lymphatics, which we'll cover as well in the vascular system. So again, you can think in many ways the cardiovascular system is a plumbing system. It delivers oxygen and nutrients to cells. It also removes the byproducts of cell metabolism. Another thing to kind of focus on as well, and you'll see this in a ton of lectures that we cover, is this Whipp and Wasserman gas exchange gears. I think this is probably the most simplified, but also kind of elegant model that describes the dynamic interplay between the circulatory system, the ventilatory system, which we'll cover later on, and the peripheral muscle system, right? These all work together in synchrony to produce human movement, right? Which we look at as a byproduct here of oxygen uptake. Now, obviously, systems physiology, we'll just be covering normal physiology, but I want you guys to think about early on in our journey here through physiology and clinical management of how different diseases may affect the function of these cogs, right? And where you may end up having one cog, for example, have to work a little bit harder to keep things balanced, right? Almost like an algebra equation. So again, we'll kind of come back to this when we get into more pathology and pathophysiology and clinical management. But I want to introduce, again, this concept that these systems kind of work together, right? They're interdependent upon each other. So our next section will cover a quick little review of normal cardiac anatomy. Again, not going to spend a ton of time on this. This is a physiology course, but just giving an appreciation for the structures that dictate the function of the heart. So a little bit of fun word, I guess not wordsmithing, but root words or etymology. The root word for heart or cardiac comes from Greek, cardia. Heart situated in the middle of the mediastinum, divided in right and left. Again, we'll kind of get over the different layers of the heart as well, but just again, quick review of the anatomy. This is a size here of a normal heart. We say most people's heart should roughly be about the size of their fist. So if you place a fist slightly to the left of your sternum, that's kind of where your heart will sit, and that's about the size it would be. This would be an example here of an enlarged heart, and we'll cover some of that remodeling later on. So that's not a good situation to be in right there. So the layers of the heart, we've got our pericardium, our epicardium, our myocardium, and our endocardium. Key thing to remember that the heart is encased in this fibrous, I guess, sac almost that kind of keeps the heart protected, which would be the fibrous pericardium, which if you've done a dissection or been in cardiac surgery, you'll see that the heart's encased in this, it keeps it protected. Also keeps it bound to the rib cage, the sternum, and it keeps it kind of in place. You can think of the pericardium in some respects analogous to the bursa that surround our joints, a similar kind of anatomy, because we also have the serous pericardium, which lines, it's kind of like the reflected end of the inside end of the fibrous pericardium, or the inside end of the pericardium, which secretes pericardial fluid that allows the heart to kind of slide and glide easily. And then we've got the pericardial space, which is the space between the fibrous pericard or the pericardium and then the epicardium of the heart. So if you think about it in layers, we've got again our fibrous pericardium again on the outside. We have the serous or visceral pericardium, and then we have our epicardium here, which is the layer kind of on the heart itself, and then this potential space in between it. So again, pericardial space, again, it's potential space. It's filled with fluid that helps reduce the friction of the heart. Think about it again, like a bursa. Bursa, secrete bursal fluid that allows or synovial fluid that allows the joints to move in a very low friction environment. The same kind of concept here occurs with the pericardium. And we have the epicardium, which surrounds the heart. You think of this almost analogous to the pia mater that surrounds the brain. It kind of keeps it intact, kind of keep things together. And then we have the myocardium, which is the functional unit of the heart. It's where the conductive cells, as well as the contracting cells, which do a lot of the work, are contained. It's like that's that layer of the heart. And then we've got the endocardium, which is a serous membrane that lines the inner surface of the heart. Now, important thing to remember about the endocardium, which I will stress, over and over again. The endocardium, right, because of that serous membrane and the way it's kind of designed, the heart does not get perfusion from the blood that's in its chambers. It gets perfused by the coronary arteries and the branches from the coronary arteries. So, which is really important to note because if we have any situations where we've got, a blockage to those coronary arteries, that myocardium, especially the deeper tissue, won't get perfused, even though right behind that endocardium, there is there's a bunch of blood. It just doesn't get into the myocardium. So again, myocardium gets perfused by the coronary arteries. Blood does not, leach out and perfuse from the chamber, from the ventricles. So again, just an example here of those tissue layers, like I mentioned here again. There's our myocardium here. There's our fibrous pericardium, our serous pericardium. And again, just remembering that the serous pericardium basically is that reflected side that secretes pericardial fluid, which is analogous to synovial fluid that allows the heart to slide and glide. Now, there are some situations we'll learn later on where this layer can get filled with fluid, pericardial effusion. There can also be situations where the pericardium gets inflamed. We call pericarditis. But again, this is just normal physiology. So we're going to switch gears and talk about the properties of the myocardial cells. And we're really getting into, again, that myocardium layer. So we've got, there are intrinsic properties here. Automaticity, which is the ability to spontaneously generate and discharge electrical impulses, or we often call self-excitation. Excitability, they can respond to electrical impulses. Basically, again, we produce these action potentials in different regions of the heart, and we're able to propagate them. The cells respond to those electrical impulses. We're also able to propagate them because they have conductivity, which means we can pass along those electrical impulses created in the SA node or other areas of conduction down to different regions of the myocardium. And then contractility, again, the ability to shorten and lengthen fibers. Some people also include rhythmicity. They have this ability to contract in a rhythmic manner. This will get really important when we start talking about electrical mechanical coupling, or how the electrical events kind of keep the heart working in synchronously together to kind of pump efficiently. But again, intrinsic properties, automaticity, those cells can spontaneously generate action potentials or self-excitation. Excitability, they can respond to an electrical impulse. Conductivity, they can propagate that electrical impulse. And then contractility, again, the ability to shorten and lengthen fibers. And you can also factor in rhythmicity as well. And again, key thing to remember is that electrical activity always precedes mechanical activity. You can think of the conduction system in the heart really as a computer or a control system. And we'll get more into that when we start going over the cardiac action potential and what that looks like. So again, myocardial cells, there's two general types. We've got conductive cells, which form the conduction system. They've got more ion channels. They have a greater potential for self-excitation, and they're distributed in an orderly fashion throughout the heart. You probably are familiar with them. You've taken undergrad physiology, the SA nodes one, the AV node, the Purkinje fibers. Again, we have, all cells within the heart have this potential, potentially, no pun intended. Um, but there's certain types of cells that have more of these ion channels, which allow them to have a higher potential for self-excitation. And then we have our mechanical cells, often referred to as myocytes, which form those like muscular walls of the atrium and the ventricles. They have, more myofilaments. They're able to, produce more force, and they're joined together by this intercalated disc, which allow for, again, that smooth conduction or propagation of action potentials and electrical impulses. Okay, so the cardiac myocyte, again, striated pattern, um, looks very similar to skeletal muscle, but it's shorter and branched. It's primarily comprised of slow oxidative fibers, which makes sense, right? Like our heart's beating from the very first, time it starts beating, 4 weeks into gestation, and then 10 weeks, or 10% of it would be type 2 fibers. Substrate metabolism is almost primarily ATP formation through oxidative phosphorylation. In terms of metabolic substrate, free fatty acids and carbohydrates, you might see lactic acid utilized in the heart at higher intensities. And then under situations of ischemia and hypoxia, you might see the heart burn through some of its glycogen stores. It's actually really important to know that there are glycogen stores. Those glycogen stores are what helps kind of reboot your heart in a certain sense if you're defibrillated. And actually, situations where you have tachyarrhythmias, which you'll learn later on, like supraventricular tachycardia, why this can be so dangerous. At those high heart rates, we burn through the glycogen stores. Thus, if we have to resuscitate that person, they don't have any substrate that kind of restart the heart. So again, remembering a little bit of anatomy or a little bit of physiology is always important to understand in terms of what we're seeing clinically. Another thing to kind of bear in mind too is the fibrous skeleton of the heart, or the annulus fibrosus. You can think of this almost as an electrical insulator and barrier between the atria and the ventricles. People often say, well, the heart's a favorite muscle, but I can't really call it a muscle because it doesn't have an origin and an insertion. Kind of actually does through this annulus fibrosus. That anchors the muscles to themselves, the anchor that the muscles anchor to of the heart, and again insulates the conduction system. And next we'll get into the heart valves. So again, we've got our semilunar valves and our AV valves. The valves respond to pressure changes, and they open in response to pressure gradients across them. So you can think of, again, they're passive structures that respond to pressure. When we contract the myocardium within a chamber, if we increase the pressure greater than the downstream pressure, right? So if we have higher pressure in the chamber relative to what's downstream or what's blocking, the valve will open. When contraction ends and pressure decreases below the downstream pressure, it'll cause the valve to close. And this will make more sense when we start getting into the specific valves, but key concept to remember, the valves themselves are passive. They have some active elements. That's more or less to kind of keep them restrained. We'll go over that, but they respond passively to pressure gradients. What a surprise. Physiology, we're talking about pressure gradients, right? So our AV valves, right? So we've got our left side, our bicuspid, also known as a mitral valve. And then our right side, we have our tricuspid valve. Okay, atrio-ventricular valves, again, they do exactly kind of as they're described anatomically. They separate the atria from the ventricles. So on this example here, we've got, again, our right AV valve, or the tricuspid valve. And then we've got on this side here, our mitral valve here. Basically, the way these valves operate is that they prevent backflow of fluid. They snap shut, right, during ventricular systole. So we want these to remain closed during ventricular systole. The idea behind this is We want to create a closed chamber or set volume so that as the ventricles contract inward, right, that pressure will raise high enough to eject blood out of those chambers, right? Whether it's into the pulmonary artery or into the aorta, right? If those valves, for example, flap open like this, we lose pressure right outside of it. What keeps the AV valves intact are the papillary muscles, which attach to the valves to the chordae tendineae, which keep them intact when the valves are closed, right? They don't pull them open per se, right? They keep them kind of like a taut umbrella tent or a taut camping tent or canopy. They keep them intact from flapping open. There are some situations where those muscles can get weakened or the chordae tendineae can get damaged, like someone who's got maybe an infarction, right? The papillary muscles can actually get ischemic and infarcted as well, or so maybe with rheumatoid arthritis, where we've got damage to the chordae tendineae, like connective tissue issues diffusely. Then we have the semilunar valves, right? Kind of named due to their half moon morphology. These open up during ventricular systole, right? And they remain closed during diastole. So the valves, the AV valves, are closed during systole and they're open during diastole. These are just, again, the opposite. The aortic and the pulmonic valves, similar kind of to the AV valves in their function. They prevent backflow during systole as the blood is ejected out, right? They prevent backflow coming back in after we pump blood out. They also remain closed during systole initially to allow pressure to build up so we can have enough pressure to eject blood out. So again, they open up if the pressure in this chamber, right, gets big enough to, or higher than the downstream pressure, say here in the pulmonary artery, to pump blood out, right, or here in the aorta to pump blood out, right. They close as the heart contracts, pressure builds, eventually to a point where it's higher in the chamber relative to these great vessels. And then during diastole, they close shut and prevent backflow going back into the heart. So again, here's just an example of what we're seeing in terms of these valves. Again, in diastole, the AV valves are open. Here, they're reflected back onto the walls of the ventricles. And the semilunar valves, the pulmonic and aortic valve are closed, right, preventing backflow from the aorta or pulmonary artery. And then we've got during systole, it's just the opposite, right? The pulmonary valve is open, the aortic valve is open, pumping into the pulmonary artery and aorta, respectively. And then we're hoping that these AV valves stay shut, right? So we don't lose pressure during systole, right? To keep a closed circuit. Next, we'll kind of go over the structures of the heart. So starting with the atria. So the atria are generally kind of thinner than the ventricles just because they don't pump, again, as high as resistance as we would see in the ventricles. So they're going to be a slightly thinner muscle wall. The left is going to be a little bit bigger than the right because the left side of the heart's typically a higher pressure. But either way, they really shouldn't be too thick because the pressures in the atria, at most, we're talking 0 to 8 millimeters of mercury. On the right side, the pulmonic side, the left side, we're talking about 4 to 12. So it should be relatively low because we're pumping into, again, those chambers. Other key thing to kind of remember is that the structures of the heart fill passively. So something that I think a lot of people forget, I don't know, maybe it's taught differently in anatomy. It's not like the atria fill first and then pump all their blood into the ventricles. When we have return or venous return, either through the pulmonary veins or through the vena cava, they're filling passively into these chambers, right? They're filling passively. They're also filling a little bit in the atria, right? Both right and left side. What happens is, preceding ventricular systole or contraction, the atria contract and provide a little bit of extra kick, about 20% of the volume or ventricular preload. So again, during diastole, when the heart's in relaxation and open back up, there's blood kind of, you know, flowing into both sides, right and left, passively. The ventricles are filling, the atria are filling a little bit as well. Prior to ventricular contraction, at the beginning of that electrical event, the atria contract, kick in the last little 20% to fill the ventricles with preload. The AV valves shut, and then the ventricles contract, right? Again, I've broken this down in a very kind of, step-by-step manner. This happens, within a second or so, right? It happens very quickly. But again, key thing to remember is that the atria and ventricles both fill passively. The atria contract, right, and provide the last little bit of kick. And we call that the atrial kick, which gives that additional volume to the ventricles, about 20% of total preload. But again, both structures fill passively in that cycle. So again, we have the ventricles, right? So we've got right and left, right, on both sides. The right ventricle, again, receives blood from the right atrium through the tricuspid valve. Again, it's going to fill passively, and then the atria will contract. And then we've got, again, to think about, again, the right ventricles will generally have a much lower or thinner vessel or ventricular wall, and that's because they're not beating against high pressures. The pulmonary artery, which is what the right ventricle pumps into, should also have very low pressures, right? We're talking about 0 to 8 millimeters of mercury, very, very low. That's why the ventricles on the right side and the atria are thinner. They're not beating against high resistance. If the pulmonary artery pressure gets too high, right, that actually can make the right ventricles hypertrophy, and that's not a good situation. We'll learn more about that later on in cardiopulmonary, but just something to think about as well. Normal anatomy, normal physiology. Left ventricle, obviously, going to be a little bit thicker, right, because we're pumping against the aorta, right, and that systemic pressure that we have, or mean arterial pressure. It's going to be about 2 to 3 times thicker because, again, it's pumping against higher resistance. And because it's thicker, it typically will tolerate increases in pressure much better than its right side counterpart. That's important to know because there are situations like when we exercise or in disease like hypertension that, the left ventricle has a little bit of wiggle room to tolerate those, increases in blood pressure. Prolonged increases in resistance or pressure in the systemic circuit can lead to hypertrophy in the left ventricle. It's not as sudden in terms of, we get to a really dangerous situation, but over time that can lead to some complications. One of the reasons why hypertension can be so dangerous because that left side, right, is a little bit more resistant or resilient to increases in resistance, and we don't detect drop-offs in performance because of that reason. So again, they pump against those valves, the aortic valve. Again, the higher the resistance in that systemic circuit, the higher the left side has to work. Same kind of concept with the right side. Right side should have much lower pressures. That's why it's thinner. Left side is going to be thicker because it's pumping against our mean, pressure. But again, either way, if resistance in the pulmonary valve, pulmonary artery, or pulmonary valve increases, we'll have hypertrophy at the right side. It doesn't tolerate it super well, so pulmonary hypertension or elevations in resistance in the pulmonary artery can be really lethal. Left side can tolerate it, but to a point. That's why hypertension can be kind of dangerous and deadly. So again, here's just an example of cross-sectional areas, just showing you the differences in the anatomy. Again, left side a little bit thicker than the right side. Again, right, left here, and then showing you the differences moving down the structure here. And again, we have different walls of the heart. Again, just talking about how we describe this. We'll cover more of this when we get into ECGs, but no, we typically divide the wall of the left ventricle into these 4 different walls: anterior, inferior, posterior, septal, and lateral. This will make more sense. I'm not going to spend a ton of time talking about this, but just knowing that we typically break these down even further into functional units, and which is kind of related directly and indirectly to how they pump. as well as how they're perfused by coronary arteries. Again, just an example again of our structures. So one thing I wanted to touch on, concepts of remodeling. So again, your myocardium are muscles too. All right, they have same mammalian targeted rapamycin complex 1 or mTORC1. They do remodel under load. Now there are some situations where that's advantageous, right? Like when we exercise, right? We're beating, we're pumping more frequently, we're working our heart muscles, a little bit more than we would if we were, sedentary. Our heart gets stronger, right? We increase cardiac output, we increase stroke volume, so the amount of volume we can pump out per beat. The heart rate decreases because we get more volume out per beat. We don't have to beat as much per minute then. And then we have other, other improvements too. But basically, the heart gets a little bit bigger. It gets, its properties though improve, right? So it's able to pump more efficiently as we exercise train, right? Or we do exercise training. Importantly, it's reversible. So just like you go to the gym, you work out, you build muscle. If you stop training, well, those muscles get smaller. They go under atrophy, right? So they hypertrophy and atrophy. In your skeletal muscles also happens in your cardiac muscle, right? So they get stronger, more resilient, they get more efficient. With exercise training, if we go in a period of inactivity, they reverse, right? It goes back to its kind of normal level. Now there can be some situations where that remodeling is pathological too. Here's just an example of that here. So we've got some examples of this remodeling. So again, just think of this as our normal reference. Under situations where we've got normal pumping, we have both an increase in ventricular mass and chamber size. Where we've got here, we've got concentric hypertrophy, where we've got a much thicker wall, right? Or there's eccentric hypertrophy, where there's sometimes a thinning almost of the wall and an increased mass. We'll spend a lot more time talking about these in our heart failure and cardiac myopathies lectures, but I did just want to introduce this concept though, that again, your heart does remodel. There's normal situations where that happens. There are also some abnormal situations where that happens, where you either have a much thicker ventricular wall, which leads to a much bigger mass. We end up having dysfunction in pumping performance. And then we have situations where it kind of gets bloated in a certain sense. It's eccentric remodeling, where the mass is increased, but it's driven to an increase in chamber size, right? And we also have impaired pumping performance. We'll talk more about these again later on in our cardiopulmonary course, situations like dilated cardiomyopathy or hypertrophic cardiomyopathies. But I did want to introduce the concept that there is remodeling in the heart. Sometimes it can be good, sometimes it cannot be so good. The key thing to note, though, is that these types of remodeling typically aren't, there are some situations where it might not be reversible too, and we'll talk about it later on too. So that's all I have for in terms of the